All right, good morning, everyone. Welcome to another AMSSM Sports Ultrasound Friday morning case series. Dr. Schaff is away today, so I'll be taking over for him for moderating today's session. Today we have Dr. Charlie Kenyon. He is a sports physiatrist and assistant professor at the University of Washington. He completed his residency in PM&R at the University of Washington prior to a sports fellowship at Emory. In addition to clinical practice, he's a team physician for the U.S. Paralympic swim team. Dr. Kenyon is going to be presenting on prepatellar bursitis. Before we get started, just another plug for the AMSSM Library of Sports Ultrasound Pathology. It's a good resource for those of you learning sports ultrasound to review common and uncommon sports pathology images, and a place for you to submit cases that you see in your clinic. And these are all reviewed and accepted and published on the website as appropriate. All right, so we'll get started with Dr. Kenyon. I will stop sharing my screen and we can move forward.
All right, guys, thank you for having me this morning, coming out from Seattle, Washington. So we're bright and early here, and then we have our weekly fellow ultrasound session after this. So a nice morning of ultrasound education out here on the West Coast. Thanks for everybody who's logging in and joining. I had the opportunity to do this case series, which was also on the anterior knee about 2 years ago as a fellow. So also really cool to circle back around now on the attending level and share some cases and images. But we'll run through cases here and hopefully have some time for questions at the end. So again, no surprise, the topic's going to be prepatellar bursitis. So our case is a 17-year-old female. She has a history of left versus right knee osteoarthritis. She's actually in the office more so for her left knee. She just basically wants a new left knee brace. Right knee symptomatic is doing okay, but she's very active. She hikes nearly daily. She lives out on the beautiful Olympic Peninsula here in Washington. She had a recent fall while she's hiking directly onto that right anterior knee. It was about 3 weeks ago. She's generally been getting around okay, but ambling better. Hasn't gotten back to all her full hiking quite yet, but she's concerned about persisting swelling around the kneecap. She's got good sensation. There's no redness and warmth. It's just kind of swollen above the kneecap. She's got good strength, and importantly, she is able to activate her extensor complex both against gravity and with some resistance, and doesn't have much significant discomfort. So there's swelling about the patella, a little bit of abrasion from the fall, maybe not some intra-articular effusion, and otherwise a ligamentously stable knee. So for those of you who've logged on before, we go through the kind of checklist protocol-based scanning. So from the 2021 curriculum here, the required structures includes the distal quadriceps muscles, the tendon, suprapatellar recess of the knee joint, the patella and prepatellar bursa, patellar tendon, tubercle, the fat pad, deep and superficial infrapatellar bursa, vastus medialis, in an ideal world, also looking through the medial right retinaculum and the MPFL dynamic testing, looking at the vastus lateralis and that retinaculum as well, taking views of the trochlear cartilage and looking at the medial and lateral menisci at their anterior horns. For this case, we used a similar protocol. Didn't necessarily do the MPFL assessment on this round, but did include looks both for the protocol and just to highlight some of the other bursts of the knee for the session today. Taking a look at the MCL and CL bursa, pace answering bursa. I know from previous sessions, it can be common for people to kind of combine elements of the anterior and medial knee protocols. So this is a patient coming in, said this wasn't necessarily her primary complaint, but with the history in the fall, certainly if she had more functional difficulty or was having trouble with her extensor mechanism, always good habit to also have some complementary x-rays, particularly, you'd be worried about any underlying fractures. So certainly could have thought about, x-rays, including lateral and sunrise views to make sure you're getting all the aspects of the patella and trying to identify any underlying fracture if that's a primary concern in addition to the ultrasound. So prepatellar bursitis, different things can cause that. Trauma, certainly overuse. Things you don't want to miss certainly are infectious or septic causes. And then any, acute onset, you might also be thinking about inflammatory or calcific bursitis, things like gout. This is an article from Dahi, just talking about different bursa anterior, the medial knee, actually throughout the knee. It basically was comparing MRI versus ultrasound in terms of identifying these bursa, but it just borrowed these clips from there. So we have our suprapatellar bursa, or subpatellar recess, the prepatellar bursa overlying the patella. And then down here is where your superficial and deep infrapatellar bursa are. This is a long axis view of the pes anserine tendon underlying anserine bursa. So just a little bit different visual than you may be used to, but just trying to give you all some framework as we get into the case images. And then also sometimes an unappreciated bursa that can lie in between the deep and superficial fibers of the MCL there at the medial joint line as well. So getting into our particular case here, I tend to start just to kind of orient myself in that common view of looking at the suprapatellar recess and distal quadriceps tendon, and then work proximally, and then organize my mind, then proximal to distal, and then including some of those medial knee structures, often in the anterior scan, but certainly based on clinical questions as well. So here we're looking at the suprapatellar recess and the quadriceps tendon long axis. Kind of formatted the slides this morning to kind of just walk through in live action how my brain's working, what I'm picking up as I go on, and we'll put it all together in the report. But see, maybe a physiologic, but certainly maybe a little more anechoic fluid there in the suprapatellar recess than I might typically anticipate. Distal quadriceps tendon, generally that looks good. We don't necessarily have it on all the way tensioned right now, but you can tell it's intact, get a little bit of anisotropy, but overall as a normal fibular trigeminal appearance so far. Up above that, we're starting to see inklings of a little more anechoic collection up here than we may look at if without the clinical picture. I may not catch that, but certainly knowing that we've seen the patient that got a big swelling, our eye is going to be tuned to that a little bit more. Flipping into the short axis now, again, we're noticing some of that anechoic fluid collection there in the suprapatellar recess, and then also doing this in dynamic action, back and forth, and sometimes do kind of a ballottement or squeeze test to see if there's more fluid in there than we may appreciate otherwise. Again, that distal quadriceps tendon short axis is looking normal. See, maybe a little bit of swelling through those superficial tissues. Then, like I said, scanning upwards. Apologize, wasn't able to upload some of the videos, but coming more into that area of the quad muscles. So we have a rectus femoris. This picture is not quite far enough up that we're getting the muscle tissue there, but it's a tendon at this level that we're looking at. Vastus medialis, medially, laterally, the lateralis, and then the intermedius underlying that. Then we'll kind of come over to the medial aspect of the knee, look at the big teardrop muscle bulk of the vastus medialis, and then envision scanning that down, capturing the retinaculum as it's inserting onto the patellar and rest of the extensor complex. This is all continuing to look normal, encouraging. Move over to the lateral side, again, scanning down the VMO, catching some of that junction into the quad tendon and lateral retinaculum, catching a little bit, again, a view in the lateral aspect, suprapatellar recess and the lateral recess as well, some fluid that's collected there. From there, bring the patient into more kind of a flexed knee position to better visualize those insertional fibers, take away some of the anisotropy of the knee, and also start to take a look at some of the cartilage structures. So here, looking at, again, that quadriceps tendon, inserting down here onto the patella. That has an encouraging look. The patella itself, I'm not noticing any cortical defects, maybe a little bit of sharpness, osteophyte related to the arthritis history, but in terms of any concern of fracture or anything, from what we're catching here, not too worried about that. And then starting to catch glimpses of the trochlear cartilage here in long axis to the tendon. And so far that looks like it's normal, typical anechoic, hypoechoic appearance. And as well as starting to see some of that swelling in those soft tissues anteriorly again. Flipping into more of the kind of short axis knee view, looking at the trochlear cartilage again. Has a nice normal appearance. Here I'm just illustrating that I went side to side and made sure we cleaned up either edge of the cartilage where you maybe have more likely to see some defect. Then tend to also kind of take a sneak peek at the medial patellar facet, going over the mediaspect and then kind of shooting back up towards the patella, deviating that a little bit, push and be able to get up, see this nice cartilage appearance of that medial facet. So that looks, again, kind of normal and encouraging. From there, just to not get to the big spoilers too early, but we'll kind of go over the patella, certainly the prepatellar bursa, and then take a look at distally at the patellar tendon. This image, you may not start with as much depth, but optimize it just to give everyone a nice appreciation of how big that fat pad is underlying the patellar tendon at this level. So I'll typically start with the long axis view, just kind of orient myself. So again, that patellar tendon has a nice, encouraging, intact fibular architecture. Excuse me. Overlying here, I'm getting glimpses again of the prepatellar bursa and some of the anechoic fluid collection in there. Fat pad appears normal. There's no big cysts or anything catching your eyes. You're dynamically scanning to make sure you get a good look at everything there. On the insertion on tibial tubercle, there's no cortical irregularity, no significant kind of insertional enthesopathy or concern for fracture there. There's a small whiff of fluid here in this deep infrapatellar bursa. It's probably normal and physiologic. Again, just to highlight for learning points, this is where the superficial infrapatellar bursa, and there's no, it's not well visualized. There's no fluid in there, and that is certainly normal. Heading over into our short axis views, dynamically scanning. Again, I tend to go proximal to distal to just keep things organized in my brain. So here's more proximal aspect, down here lower, getting distal onto the tibial tubercle. So the tendon itself, we see normal appearance, normal thickness, normal architecture of the patellar tendon in a dynamic view going short axis, proximal to distal. And again, in this short axis view, we're again seeing as we come distally towards the tubercle, that infrapatellar bursa has some fluid in it, but doesn't appear to be tender to sonal palpation or complaining of pain in that area. So likely normal and more incidental. Peeking over at the anterior horn of the medial meniscus now. This has a nice hyperechoic position. It's not wildly extruding or anything like that. So in 72-year-old female, probably calling this largely normal. Kind of starting to peak overlying there at the MCL as it's coursing proximal distal there. See a little bit of normal appearance of the MCL. See some of this hypoechoic, anechoic collection through here. It's most likely going to be some fluid extending from the joint recess, but certainly something like a perimeniscal cyst would be on your differential there as well. And like we talked about, an underappreciated bursa of the knee can be in between the deep and superficial fibers of the MCL here. And we're not seeing any collection between the MCL. So we will say MCL bursa is not well visualized. And again, that's a normal thing. Part of the learning from this case is if you scan something that's not giving you too much trouble and somebody with some arthritis, you're going to start to see some abnormalities and then have to make decisions about what you do with that. So as we scan distally through the MCL, taking a look at the pes anserine, the MCL itself coursing through here generally looks intact. Mostly looking at the long axis views here. We have the luxury of having a high frequency machine here and able to well visualize the genicular vessels. This is the artery, probably looking at the genicular nerve coming through here. Through here where the pes tendons are coming at you in short axis. That looks to be a little thickened with some hypoechoic change. And then there's this other kind of anechoic thing here. It's uncertain, if a vessel seems to be a little bit bigger than typical vessel. It's not necessarily pulsatile. Doesn't have any Doppler flow when we had put that on. Then you see some kind of fluid looking collection down through there too. So kind of wondering what that is. It just catches your eyes, not being normal appearance of what you would typically expect. And there's, again, the kind of some of that fluid collection through what may be the pes anserine bursa through there. Switching now, kind of most people tend to look at this area in this view, but certainly good practice to turn on those pes tendons to their long axis. And underlying there, we see some kind of multi-collection anechoic fluid through that bursa. Here over on this side is, again, some anechoic collection that correlates with that other lesion that we were looking at earlier. Apologies, we don't have the videos. But this is some thickening hypoechoic change. That pes tendon is coming down through there. We got the multiloculated appearance of the bursa with anechoic collection through there. And there's no Doppler flow in that area, so we're not thinking this is a vessel. And this was Doppler was put on these other areas and looked at dynamically as well. Checking out the lateral meniscus again. This is an older active person, so now we're seeing in an area that wasn't necessarily causing symptomatic complaint, but there's some compared to that medial anterior horn, the medial meniscus, there's a little bit more kind of irregularity through there. Probably some extrusion of that lateral meniscus. She's not tender in this area, but we're going to call this something like complex appearance of the visualized aspect of the anterior horn of the lateral meniscus with apparent extrusion there. So now we're getting to the core of the presentation today, getting into the area of the prepatellar bursa. Had a lot of spoilers, so I hope everyone still is hanging on the edge of their seats for this. But as we're coming through here, certainly we're now seeing the entirety of that anechoic collection there through this area overlying both the patella and the patellar tendon. As we saw from our different views earlier, as we moved and flexed and extended the knee, some of this was compressible and moving around a little bit and catching clips of it in different views. But here in long axis is the entirety of that collection. So if not measured, which would probably be a good habit, but we're going to call this moderate anechoic fluid collection within the distended, but still compressible prepatellar bursa with hypoechoic thickening of the surrounding bursal tissues, as well as some bursal tissue that's noted in through here. So there's no significant cortical irregularity through the patella. So you're also kind of, again, encouraged by her clinical exam and ability to activate the extensor complex with some good resistance and minimal pain, but also taking a good thorough look through the surfaces of patella, make sure you're not missing any irregularity or potential fracture that may be underlying there. And then another thing you're going to notice here is the amount of gel, and even more gel to achieve that standoff to make sure that we can appreciate the whole bursa. Flipping on our Doppler again, making sure this isn't something that's more inflammatory in nature, but overall that Doppler exam was encouraging. So no significant power Doppler flow of the bursa. And here are just some kind of complementary images of the knee kind of in different positions, a little more flexion here so you can better visualize that insertional fibers of the proximal patellar tendon there, and also some of that contiguous extensor mechanism tissue as it's coming across the patella. So getting into our report, just kind of logistically, saying what we're doing, the complete ultrasound evaluation of the right anterior knee. I performed this, we'll say it's today's date for the sake of argument. We were using a linear transducer, 2 to 14 megahertz, and that was with adjustments and optimization appropriate for use throughout the scan. So my style, I'll fully admit that I'm pretty rare that I'm doing a complete report. But when I do, I kind of have the images all in front of me, and I tend to do more kind of dictate as I go through, again, kind of thinking of proximal, the distal in this case, and then some of the medial structures of the knee, but just kind of having my thought process and then kind of stepping back and going through. I don't tend to use a lot of templates right now, but I tend to just kind of, for my own benefit of looking through things again, we'll look at it and kind of dictate as I'm looking through the images. So we felt the quad tendon was intact with normal echotexture, normal appearance of the muscle bellies of the quads. There's appropriate appearance of the retinaculum, both medial and laterally, minimal anechoic fluid collection within the suprapatellar recess of the knee. So the trochlear cartilage looked good without visualized defects in the areas that we were able to look at. Cartilage of the medial patellar facet also looked good. Commenting again clinically in the scenario with the trauma that there was no cortical irregularity at the patella. The really core of this report is what's going on with this big swelling that's going on in our anterior knee, and we just call that a moderate compressible distension with anechoic collection noted within the prepatellar bursa. There's hypoechoic thickening noted of the surrounding bursal tissues. No significant Doppler flow of the bursa or surrounding tissues. Then again, kind of in my mind, walking through, looking at the images again from there where we're going, continuing distally, looking at the patellar tendon and the extensor complex in more detail. And the tendon was normal. There wasn't any enthesopathic change or cortical irregularity at the tibial tubercle. Normal appearance of the underlying fat pad. Again, we kind of highlighted that we saw some fluid collection within the deep infrapatellar bursa, but called that a mild physiologic collection, given that wasn't having any symptoms, and can be certainly a normal finding. Then the anterior horn and medial meniscus looked good. When we looked at the lateral meniscus, we saw some of that what we'll call complex change with a little bit of extrusion, and just making sure that we're trying to communicate that that wasn't necessarily symptomatic, so there wasn't any corresponding tenderness to sonal palpation. Looking at the MCL, we call that a normal appearance. There was that hypoechoic collection underlying the MCL that most likely is just some communicating fluid from the joint space. But do consider the meniscus list. Then looking through under that where the genicular nerve vasculature was, we'll just call that well visualized there. And then also noting that anechoic area that was not necessarily in our first views in that typical area of the pes anserine bursa, but potentially could it be extending from the bursa versus separate cystic structure related to the trauma or otherwise. And then again, commenting on that pathology we saw in that pes anserine area of the thickening and hypoechoic change of the tendons in both short and long axis. And then commenting again on that collection, the pes anserine bursitis node flow in that area, and also being sure that we clarify that this didn't seem to be a symptomatic area, so there wasn't any significant tenderness to sonal palpation in the area. So overall, kind of then summarizing this in a global impression, and as sports medicine physicians compared to our radiology colleagues, we'll have likely more information in terms of clinical exam and context when we're doing this. So try and communicate that in the documentation as much as possible. So we'll call this a moderate bursitis of the prepatellar bursa, and without significant Doppler flows correlates with the post-traumatic bursitis consistent with clinical exam and the history of recent direct trauma. Again, just being clear that we don't see anything where we're concerned with fracture of patella, just given the impact on the area. So no cortical irregularity on the patella to suggest a cold fracture. Otherwise, appropriate appearance of the extensor mechanism. And then, maybe not in a arthritic knee commenting on every single thing, but some of the things that really jumped out at you. So likely incidental finding of chronic complex degenerative lateral meniscus change at the anterior horn of the medial meniscus, and then also commenting on that pes bursa area, the moderate pes anserine tendinopathy with associated pes anserine bursitis without corresponding tendinous zona palpation. So kind of wrapping it up, taking it home here. Learning points, even for a presentation like this, we may be very tempted just to place the transducer on that area of swelling, take a look at the bursitis directly, just kind of sticking to your guns, being very systematic and working through your process. Be problem focused, but maintain a broad differential. And like we highlighted here, you're also got to be prepared for incidental findings. And then your responsibility, again, the advantage you have as a sports medicine physician doing this is that likely you've gone through history and physical exam, and you have the ability to interpret things clinically a little bit. So make sure you're doing that both with your exam and your history, and being thorough both on your own scans and any consults you might see. So thank you guys. Excuse me. Up here bright and early for everyone logging on and who may be listening in the future. Here's some of my contact information. Please feel free to reach out at any time.
All right, Charlie, thanks so much. That was a great presentation, great protocol, driven presentation, which is obviously one of the goals of this session. Before I make any comments, I'll open it up if anyone has any questions or comments they want to say first. You're welcome to. I'll give you a second. All right, I don't see anyone speaking up here, so I'll just make a couple of comments. I think, one of the things, Charlie, that I get referred, fairly frequently, and I don't know if you've seen this as well, is I'll get, referred like a swelling on the knee kind of diagnostic eval, like do they have a pes bursitis or prepatellar bursitis? And I'll say quite frequently, kind of in this demographic population, it's actually just a fatty deposit that you see. And so having that kind of resisting that urge to say, like, I'm just going to throw the transducer down right over the patella, I'm going to find a bursa, and then I'm going to do whatever I want to do, is clinically appropriate with that. Having that kind of discipline to say, like, I'm going to start proximally and I'm going to work myself distal, and I'm going to look both medial and lateral, but kind of within that anterior space, is a really good way to approach this. And it helps so you're not missing other diagnoses, right, that maybe would be more pertinent, or things that you maybe would want to be able to share with the referring doc. So that's certainly, one portion of it. And doing it the way that you did it, and resisting the urge to just jump straight to the prepatellar bursa, even though you saw that on your initial images, you saw that when you work distal, is a great way to approach this, and that makes sure you don't skip things. And I think that's kind of the primary factor in doing these kind of protocol-based evaluations. You know, I've oftentimes struggled, Charlie, and I don't know what your thoughts are on this, of like, where does the prepatellar bursa end and where does the infrapatellar bursa start? And as far as I understand, the prepatellar bursa has been relatively well described anatomically, and in the infrapatellar bursa less well. So I tend to kind of call it infrapatellar bursa when it starts getting into the meat of the patellar tendon, and prepatellar bursa extends up over the patella. But then the other thing that kind of encompasses both that you'll sometimes see is a Morel Lavalley injuries. You'll see those kind of internal gloving injuries. And can you remind me, Charlie, how acute was this after the injury, after
It
the
was a
direct
few.
trauma?
It was a few weeks. Yeah, and again,
Yeah.
it was it was between the time that
Weeks,
I
not
committed
months.
to the I committed to the topic, and she happened to come in, and I was like, oh, this is a great opportunity to get some great images for the presentation, but really all
Yeah,
she wanted was a knee brace for her other knee because that was been old and broken up. So
yeah,
that's but yeah, absolutely. I think the scenario within the last year that I wish I had pictures from, but covering the state wrestling tournament,
yeah,
the amount of acute, huge, superficial bursitis issues, that we saw there, certainly would have in the portable scanning that we were doing, saw that more so. Like you're saying, we have this huge collection, and you know one versus the other. Then there's probably a component of morale levelly there too in that setting. But certainly that's the clinical scenario where I've been most impressed by collections in this area. Just how big they get from that, both acute and chronic trauma those guys go through on the mat.
yeah. That's what we've. The wrestling population is definitely a challenging one there because they have features that would both cause prepatellar bursitis, right? They're kneeling
Mm,
frequently with load, and then they also have features that would cause the morale levelie, right? They're shooting and they have a shearing force going through their knee as they're sliding. And so those are can be really challenging to evaluate and understand kind of what is the diagnosis. And the way I've typically approached it is if it is extending across kind of what I would consider to be both bursas, and if it extends over the quad musculature, like medial
mm,
lateral, I tend to call it morale levelie, and if it stays more localized to the anterior knee, I'll tend to call it a prepatellar bursa. But then as you progress out from the injury, the morale levelies tend to kind of create that capsule that's
mm,
pretty echogenic and well defined relative to the anechoic fluid internally, and that can help you differentiate between those as well. And so those are kind of the things I always think about with this. Um, yeah, otherwise, there's certainly challenging in this population, right? As we age, our skin thins, and that makes it more challenging to manage these, and more likely that individuals will, have this diagnosis. But yeah, in any case, I'll open it up
mm.
for any other questions. I don't know, Ryan, if you have any thoughts on kind of what I was saying previously about the morale levelie and Bursa.
Hey, Brent, this is Ryan. Can you hear me?
Yep.
Yep.
All right. Charlie, thanks for doing this, man, and great
Yeah,
talk. And
absolutely.
yeah, appreciate you getting up at the super early West Coast time. So,
Yeah, I
um,
made those guys sweat just a little bit logging on, but we made it.
yeah, the only, and you may have said this, and if I did,
Mm,
or if you did, then I apologize. But the only thing that I would add, well, let me back up. I agree with you completely, and what Brennan said as well. It's easy to see a focal fluid collection. This is a bursopathy. I'm going to throw the transducer on. There's my answer and move on. But the importance of doing a protocolized scan here is critical, like you both alluded to, because you're going to pick up other things that you may not have expected, such as the other fluid collections and bursopathies that you saw in this patient. The only other thing that I'll add in here would be evaluation of the saphenous nerve, specifically the infrapatellar branch. Also, that also helps again complete the requirements for a complete examination. And I've seen one case where the infratellar branch, as it starts to take that turn and course anterolaterally, I've seen a moderately sized neuroma in that area, and that presented as kind of a small quote unquote bump on the anterior knee. Now, certainly this is going to be caudal inferior a bit to where a prepatellar bursopathy or bursitis would be, but just something else to keep on the differential there.
mm,
In terms of differentiating a moral levelie versus a prepatellar bursitis or bursopathy, clinically, it probably doesn't matter all that much, but sonographically, what I've seen, and I don't, to be completely honest, know if this next statement has any merit or if anybody agrees with this, but what I've typically seen is, with a moral levelie or an internal degloving injury, that fluid collection is going to be purely between subcutaneous tissue and deep fascia or deep muscle, right? Versus these prepatellar bursopathies really don't have that clear delineation, and sometimes that fluid collection can somewhat, merge its way into the subcutaneous tissue. And so that, to me, that's how I've somewhat differentiated between the two. Again, purely deep to subcutaneous tissue, more lovely, somewhat creeping into subcutaneous tissue with not as well of a defined border, more of a prepatellar bursitis. But again, probably doesn't really matter all that much clinically, but just curious what y'all think about that.
Yeah, I think that all makes sense. I think we touched on it, we're going through it, but just to kind of double down for the fellows on the call, you can miss some very subtle collections if you're maintaining your normal probe pressure. So even in the situations where you may feel that it looks pretty normal, make sure you create a little bit of standoff and look through those tissues, either for some of that shearing, more lavely type thing we're talking about, or more the classic bursal, whether it's thickening or fluid collection. I think it's important to, as we're talking about being protocolized through whatever the anterior knee complaint would be, to just make sure you create some standoff there and appreciate what's going on, not only in the tendon and patella, but the superficial tissues.
Yeah, Ryan, I think you definitely brought up a good point there. Charlie, on your images, you could see that fluid was kind of interdigitating with some hypertrophic synovial sort of tissue superficially.
Yep.
I every now and then I've seen some morale lavalies where you'll have some internal echoes related to either debris or fascia or something extending through it, but it's definitely less notable than the pictures that Charlie showed there. So
the only other thing clinically, I would say in this scenario, in this older female, maybe has some bone density issues that fell. She was again a couple weeks out and walking well, but for the fellows listening, certainly I've seen similar situations, whether it's fall in the bathtub, little different injuries where they've had normal x-rays, may have some ultrasound findings, but things just the amount of functional limitations way bigger than you'd think just from a little bursitis, particularly with tenders like in the pants area. So I'll at times have lower threshold to get more advanced imaging and make sure we're not missing tibial fracture in those scenarios. But other than that, thank you guys for having me.
all right, excellent. Well, unless anyone else has other questions, I think that'll wrap up for this week. We'll be back in 2 weeks on September 27th. We'll have Dr. Michael Seifert presenting on sternoclavicular joint sprains. Have a good weekend, everyone.
Thanks, everybody.